Next up, I'd like to introduce someone that's special to me, at least in my practice. Nadia Blessing works with me. She is a physician assistant here at Indiana University School of Medicine. Nadia has worked with me closely this past year in my own clinic, and much to her dismay, she's become an autoimmune expert in her own right, particularly the nuances of care. And the worst thing about it is she's a lot better than me as well. So my patients have grown quite fond of her, which is good. But I've asked Nadia, because she is such an awesome clinical educator, to talk about preventative health strategies in AIH, which unfortunately I think is commonly missed by PCPs and hepatologists alike. So please join me in welcoming Nadia Blessing.
Hello. He's typically not that nice to me. My name is Nadia. Thank you for having me. I'm a PA at IU Health. I work with Dr. Lammert in the general hepatology department. I have a few questions to start with, if you guys don't mind. I just have some polls. So the first one is, do you get a yearly flu vaccine? Oh, good. So we've got about 75% yeses. Next up, if you are a patient with autoimmune hepatitis on immunosuppression, do you follow with either a dermatologist or primary care provider for yearly skin checks? I've got about 68% yeses. And then do you routinely get preventative healthcare screenings, colonoscopies, mammograms, bone density scans, et cetera? So we've got about 86% yeses, 81. Okay, awesome. So we'll kind of touch base on those later. So some goals of my talk today. First thing I want to do is just discuss routine healthcare screenings. So healthcare screenings, these are healthcare maintenance guidelines for all patients, children, adults, but we don't get a lot of time. Dr. Lammert and I typically get like 20 minutes with patients, so often these are not going to be things that are discussed. So I just really want to make sure as patients you are familiar with these and can help advocate for yourselves and introduce the topic when you do come in to see us or see your primary care doctors. But just to discuss the importance of these routine screenings. Some of these things, we'll talk about cancer screenings, we'll talk about bone health, some mood disorders, but honestly, just education and then helping you guys advocate for yourselves is most important. So health maintenance guidelines, again, these are things, the number one thing is prevention, so just routine normal screening guidelines. We'll talk a little bit about cancer risk in patients with AIH. I'll go through kind of some different cancer screening guidelines. We'll talk about bone health, and then we'll also talk about some other concurrent immune diseases. So cancer risk in patients with AIH, there was a study published in the American Journal of Epidemiology. There was a study done in Sweden, had over 5,000 patients with AIH, but it did show that patients who do have AIH, who we consider immunocompromised, who are on immunosuppressants, have been shown to have an increased risk of developing cancer. Specifically, in patients who have AIH and cirrhosis, we see increased risk of liver cancer. And then otherwise, you can see skin cancer, lymphoma, cervical cancer, et cetera. So very important to know that we should be as providers routinely screening you. Highest risk is for liver cancer is going to be especially seen in patients with cirrhosis. So per AASLD guidelines, so the American Association of the Study of Liver Disease, there is a 1 to 9% increased risk of cirrhosis in patients who do have AIH and who have cirrhosis. So with AIH, the goal is to achieve biochemical remission with medication, with treatment, with those immunosuppressants. However, if there is still inflammation in the liver, it can lead to increased scarring or progression of fibrosis or scarring in the liver, which can then lead to cirrhosis. Once a patient does have cirrhosis, it's important to know we should be screening you every 6 months, typically with imaging per guidelines, whether that's through ultrasounds, CT scans, MRIs, but very important that we're doing routine liver cancer screening. Colorectal cancer, so this one is just kind of across the board. Newest guidelines from the American Cancer Society say starting at age 45, all adults should be getting screened for colon cancer. A lot of people prefer to do more of a stool-based test rather than a visual test like a colonoscopy. If you do end up getting a Cologuard, which comes back positive, you're still going to require needing a colonoscopy. But very important to start screening at 45 now instead of at 50, which was the older recommendations. We do recommend screening through the age of 75. From 76 to 85, truly it depends on the patient, your overall health, comorbidities, provider-patient preference, and then post-85, it's no longer recommended to get colorectal cancer screening. Cervical cancer screening, so starting in women at age 21. Older guidelines used to say yearly with yearly pap smears. Newer guidelines say every 3 years is okay in women who are 21 to 29. And then once you're 30 to 65, every 5 years is even okay as long as they're doing both cytology. So during your PAPs, collecting cells, sending those for pathology, checking for cervical cancer. But if also co-testing for HPV, human papillomavirus as well, then every 5 years may be okay. When to discontinue? If you had a total hysterectomy and you don't have a prior history of cervical cancer, and then if you're over 65 and you don't have any prior history of abnormal pap smears. And then again, co-testing is also important for HPV. Another important one in women, breast cancer screening guidelines. So starting at age 40, women should be getting annual mammographies. When to discontinue with this one, you can continue to get screened until, if you're still in good health, there's not really a clear discontinuation guideline. Clinical breast exams are also important, again, every 3 years in women who are going to be in that 20 to 39 range. But then when you hit 40, we do recommend annual breast exams as well, along with your mammograms. So with patients who have autoimmune hepatitis, discussing earlier on increased risk of malignancy, skin cancer is definitely one of the more common ones. Studies have shown that up to 5% of patients with AIH on immunosuppression may develop skin cancer. And patients should undergo, and this is something I know Dr. Lammert and I are pretty good about discussing with our patients, but we do highly, highly recommend annual yearly skin checks if you are on immunosuppression. So typically it's important whether it's through your PCP, but getting established with a dermatologist for annual skin checks, we do recommend. Switching from cancer screening to bone health. Bone health is also something we try to touch up on pretty regularly. So DEXA scans, bone density scans really should be performed at baseline in all patients who have any risk factors for osteoporosis. So these are going to be the use of steroids, especially prolonged use of steroids, which we see often in patients with AIH, women, older age, lower BMI, postmenopausal women, women typically over 65, but we do highly recommend, especially in our patients who are on immunosuppression, we should be really getting DEXA scans about every 2 to 3 years to evaluate bone health and that risk of osteoporosis. In our patients who are on glucocorticoid therapy, we should also be discussing with you guys going on calcium and vitamin D. If the DEXA scans do show that osteoporosis is a diagnosis, we do recommend, I've had patients ask me before if we recommend going on therapy like bisphosphonates, and we do. So treatment to just help reduce that bone loss and help with bone regeneration. And then Dr. King touched up on this earlier, so studies have shown, and per the AASLD, 14 to 44% of patients with autoimmune hepatitis also have other autoimmune disease. So it's important for us as your providers to be screening for other autoimmune disease as well. whether that's thyroid disease, diabetes, other diseases such as rheumatoid arthritis, often irritable bowel disease, Sjogren's. So a lot of it also based on your symptoms, dry eyes, dry mouth for Sjogren's, et cetera. But we should be testing for other disease as well. So I'll kind of move on now and talk more about vaccinations and immunization schedules. So Dr. King touched up on this earlier as well. So in autoimmune hepatitis, we have these T cells, these lymphocytes, these cells which are attacking our healthy liver cells. So in order for us to help our patients with AIH get biochemical remission and get the proper treatment, most of the time we have patients on immunosuppression. However, then this is blunting your immune response to any foreign cells. And so vaccines are very important. As much as we can try to maximize a patient's immune response to so many of these vaccine-preventable illnesses, we do want to make sure that we are doing that. A lot of times you're going to get more of this information from your primary care providers rather than from a GI provider or from a hepatologist, but again, it's important for you guys to know that these are preventable illnesses, and in somebody who is immunocompromised or immunosuppressed, the incidence of and also the severity of these preventable illnesses would be just a lot worse. So we absolutely recommend getting vaccinated just to be able to maximize your immune response as much as possible. So again, vaccines are important for the prevention of a number of infectious illnesses, and it's important for patients with AIH. We'll talk about this a little bit more, but there are recommendations that patients with AIH on immunosuppression get vaccinated prior to starting on immunosuppression, but this really does apply more to live vaccines rather than non-live, and I'll talk about that next. But something else to keep in mind, family members, household contacts, people that you live with, should get vaccinated as well, just to reduce your exposure. So live versus non-live, most of the vaccines that we recommend that patients get, that we get, are going to be non-live, inactivated vaccines. Live vaccines are typically going to be contraindicated in people on immunosuppression, and this is because if we're introducing this foreign bacteria, virus to a patient with immunosuppression, you're not going to mount that same response as somebody in the general population. So this can lead to just very severe infection, viremia, bacteremia, and we want to prevent that. So we don't typically recommend live vaccines. So I'll talk about a few different ones. So to begin with, flu, recommend the flu vaccine starting at 6 months old in everyone annually. There is a higher dose flu vaccine for patients 65 and over. But again, this is an important one to keep in mind for household contacts, so anybody that you're living with, just to help reduce your exposure as well. Pneumococcal, also inactivated or non-live. Pneumococcal, so AIH patients certainly are at a little bit of a higher risk of developing pneumococcal pneumonia rather than the general population. Guidelines for pneumococcal vaccines can get a little bit tricky, so I've got some diagrams to kind of help us. But there's two main kinds of vaccines. There's a conjugated, you may have heard the most common was the Prevnar 13, and then there's a polysaccharide, which is the 23. In regards to the conjugate vaccines, there are newer vaccines now, which are the PCV 15 and 20, so the newest guidelines involve these as well. And the number correlates with the amount of strains covered, but really you do want to be covered overall by both. So older guidelines said that in patients who were receiving immunosuppressive therapy, you really should be getting both vaccinations. Specifically, patients between 19 and 64, you typically started with that Prevnar 13. A year later, got the 23 polysaccharide vaccine, and then you got another booster of the 23 about 5 years later. But we'll talk about that more. So vaccine is going to be recommended in patients on immunosuppressive drugs with chronic disease, chronic liver disease. This is more of a vaccine timing for adults in the general population. So I'm going to focus more on this one, patients with immunocompromising conditions or who are on immunosuppression. So the newer guidelines say that if you have not gotten any prior pneumococcal vaccine, then you can get the conjugate, the PCV15 vaccine, and then 8 weeks to a year later, get the 23. A lot of times, though, a booster may still be required. Other guidelines say that you may just be okay just starting out with the conjugate 20 and not require a booster. I think a lot of this also depends on where your primary care doctor is, what vaccines your office is offering. So there's just a lot of different regimens. So it's important for, I mean, I don't know this by heart, so all of us would have to look it up. So it's just important to know to talk to your provider about it, so we can just make sure we've got you on the correct vaccines and the right regimen. And then this one is again referring to vaccination for pneumococcal vaccine in chronic health conditions, so specifically patients with chronic liver disease. And again, if you haven't had one before, coverage may be good just by getting that pneumococcal, the PCV20. But again, another option is to start with the 15, a year later get the 23, and then whether you require a booster or not in the future really will just depend on what vaccines you kind of started out with. COVID, we do recommend COVID-19 vaccine, so whichever one is available, whether Pfizer, Moderna, Johnson & Johnson. Again, the goal here is just to maximize your immune response to this vaccine-preventable illness. Herpes zoster or shingles vaccine, so that's going to be your Shingrix. This is inactive. We do recommend this. Typically, it's in adults over 50, but in patients who are on immunosuppression, we do recommend 2 doses, even starting at the age of 18. Varicella chickenpox gets a little bit tricky. This is going to be one of your live vaccines. So ideally, this would be good to get 4 weeks prior to starting on immunosuppression. And it's important to check titers as well, but because of it being live, it would be contraindicated in patients on immunosuppressive therapy. HPV, another inactive vaccine. Patients who are on immunosuppression have been shown to have about a 30% higher risk for developing cervical neoplasia compared to the general population, so definitely important. It's a 3-dose series. Previously, it used to be recommended ages 9 to 26, but now it is available to those 27 to 45 as well. Tdap, tetanus, diphtheria, pertussis, absolutely recommend. Typically, it used to be a single dose between 11 to 64. In our patients who do have liver disease, advanced liver disease, cirrhosis, we do recommend at least once every 10 years. Something else for Tdap to keep in mind in women of childbearing age, if you're pregnant, and then anybody around you who's going to have access to baby, it is recommended to have to get a Tdap vaccine as well to reduce risk of exposure to baby. Hepatitis A and B, these are ones that we routinely check for. We check titers prior to immunizing, check immunity. Good thing is now there is a combination vaccine, a 3-dose series combo vaccine for both Hep A and Hep B, but it's definitely one that we highly recommend. MMR, measles, mumps, and rubella, another one like the varicella vaccine because it is going to be a live vaccine, so typically contraindicated in patients who are going to be on immunosuppressive therapy. But again, varicella, MMR, and then meningococcal, which I'll get to, these are typically going to be required in more of a younger population. With the meningococcal, there's 3 different types of vaccines licensed in the US. Things to keep in mind though, if somebody's in the military, if they're going to be traveling to a certain endemic area, if they have sickle cell, a damaged spleen, those are other risk factors to keep in mind as well for getting the meningococcal. But again, more so this is for school-age kids, college students, etc. And then travel medicine. There's a lot of different travel medicine providers out there. Primary care providers would likely know a little bit more about this as well, but there's several travel vaccines. Important to know, though, if you're going to a certain area, endemic for certain diseases, what you should be protected against. But also important to know if those are going to be live or non-live vaccines if you are on immunosuppression. So for example, yellow fever, not typically recommended if you're on immunosuppression because it is live, but these are important things to talk to your provider about as well. And then lastly, I just want to talk about some other tools for screening. So smoking is something that we should routinely be talking to you guys about as well. So smoking is going to blunt your immune response, lower the immune system. And so if somebody is already on immunosuppression, it is important for us to be screening your smoking status at baseline, and to help provide you with, smoking cessation tools, therapy, et cetera. And then mood disorders, depression, anxiety, these are often seen with autoimmune disease, autoimmune hepatitis. Typically, patients are going to be screened more so for these, or can be screened through surveys from your primary care provider. There's specific surveys, a GAD-7, a PHQ-9 for anxiety and depression. And then a lot of this, if it's untreated, can also play into further fatigue with patients who have autoimmune liver disease. And so just important that we are screening you for these, and if you do screen positive, specifically primary care providers or us as much as we can help, but that we are getting you appropriate counseling and therapy. And then lastly, I just want to finish up with some cirrhosis, specifically cirrhosis preventative care recommendations, some things that we more commonly talk to our patients who have cirrhosis or advanced liver disease. So absolutely recommend yearly flu vaccines, recommend routine pneumococcal vaccination, Tdap typically once every 10 years, checking for immunity for Hep A and B, and if not immune, absolutely vaccinating. And then pain management is a common one. We get asked about this a lot. We do prefer Tylenol as long as it's not over 2,000 milligrams a day. Compared to anti-inflammatories like Advil, Aleve, ibuprofen, naproxen, Motrin, just because there's some increased risk more so with the NSAIDs, for example, increased risk of a gastrointestinal bleed, affecting the kidneys, and then also further decompensation of worsening of certain complications of your liver disease, of your advanced liver disease. And then one that I talk to patients often about that people are typically not very familiar with is a specific bacteria called Vibrio, which is found typically most commonly in raw oysters, raw seafood. So we do recommend staying away from those because certainly if the immunocompromised patient gets an infection, it can be life-threatening. So we do recommend avoiding those, staying away from them. Raw oysters, absolutely. I just tend to stay on the safe side and say just being very careful with raw seafood as well. And then also avoiding, if you have any open wounds, breaks in the skin, to not swim in like open water, seawater, etc. So to end with, the goal of this talk, the biggest thing is just to help educate and help you guys advocate for yourselves, just to be, not to know exactly what the guidelines are and how often to get screened. That's our job. We should do that for you. But just to know that you should be advocating for yourselves and know that there are these guidelines that you should be routinely getting screened for these vaccine preventable illnesses, for these health screening guidelines, that there is a little bit of a higher risk for these illnesses and malignancies in patients with AIH. So just important to know, just as part of an all-encompassing healthcare experience. Thank you.
Thank you, Nadia. That was really insightful. A lot of word soup, but again, you can maybe start to see how complex this is, yet again, between hepatologists and primary care doctors to make sure you are doing the best preventative strategies. I think we put a little bit back on the patient's shoulders, and I think that's important from this group as well. Does anyone have any questions for Ms. Blessing?
Yeah, so about the Tylenol versus Advil thing, I'd always heard to avoid Tylenol and to take Advil instead. Is that like a new thing, or?
It's not a new thing, but what you are saying is absolutely the more common thought. That's absolutely what people say, that if you have liver disease, you should just stay away from Tylenol. But certainly, studies have shown from our experience, Tylenol is definitely safer from a liver perspective, just as long as you're not going over that 2,000 milligrams per day. There's just more risks that are involved with the anti-inflammatories.
Yeah, kind of along the same lines. What about Voltaren, the topical?
Topicals, topical's fine. Topical's okay.
What would you say to a patient that's adamant about receiving a live vaccine, or if they're due for one, would you be adamant that they don't proceed with it? Because it can get tricky if it's a live vaccine, but they're also due for the vaccine and immunocompromised.
I mean, it certainly is contraindicated just because there's such a higher risk of severity of being exposed to that foreign bacteria and infection. So I personally would not recommend it. What would you say, Dr. Lamert?
I would agree. I think you have to discuss it with the doctor in terms of theoretic risk.
Yeah.
Which one in particular, may I ask? What vaccine in particular?
I was just curious in general.
Oh.
Well, thank you. One more.
Let's do it.
Can you repeat, you said something about Johnson & Johnson really quickly. Do you have a recommended COVID vaccine or do you recommend that we get COVID vaccine boosters?
Just recommend, yes, absolutely. Anyone that's available to you.
I have a question about the shingles vaccine.
Mm-hmm.
My mom is an AIH patient, and she got shingles, and right after that, she got diagnosed with AIH. And she never had the shingles vaccine. So in this case, do you think she still needed, or? And she's kind of against that idea because in her mind, she feels like there's some relationship between her shingles and her AIH diagnosis. So I just want to make sure, I bring the good information back to her.
I personally would still recommend it. I think I'd have to look a little bit more at guidelines, but again, you just want to, maximize immune response later on. If she was exposed once again, you just
So
want
you
to.
can get shingles more than once?
Yes.
Okay.
Well, thank you all.
Okay. Thank you.